Okay, we're going to go ahead and get started here. I lied. I do have one more dad joke, so for research. What did the biologist wear to impress his date? Designer jeans.
Okay.
I got a better one.
Okay, we're going to go ahead and get started. If you can sit down. The topic is on what is new in PD research. We are honored to have Dr. Webster Ross here. Dr. Ross is a neurologist investigator at the Department of Veterans Affairs affiliated Pacific Health Research and Education Institute, working on epidemiological studies of neurodegenerative diseases of aging, including Parkinson's disease, and correlating clinical findings with neuropathology. These studies involve the Kuakini Honolulu Asian Aging Study Cohort, established in 1965 at Kuakini Medical Center. He has also been involved in clinical trials of symptomatic and potential disease-modifying therapies for Parkinson's disease, and is a clinical professor of geriatrics at University of Hawaii, John A. Burns School of Medicine. Dr. Ross received his residency training in neurology at Tulane University in New Orleans and fellowship training in behavioral neurology at the University of California. He is a staple with our symposiums and always offers great new information on what's going on with Parkinson's. I'm going to turn it over to Dr. Ross. Thank you.
Thank you. Thank you very much, Kevin. It is such a pleasure to be here. I've been to many of these, and they just keep getting better and better every single year. And the panels this morning have just been excellent. And I hope I can hold your attention, because I just really appreciated the excellent presentations already this morning. So I'm going to be talking a little bit about research. I don't have any financial disclosures, but I will be talking some off-label use of already approved medications. This is in experimental designs, so I just want to let you know that. In terms of my joke, termite walks into a bar, says, "Is the bartender here?" Okay, here we go. This is what I'm going to be talking about. There are so many things happening in Parkinson's disease research right now that it's really impossible to go over all of them. But there are a couple of things that I'd really kind of like to cover, because to me they're very, very exciting. And they answer two fundamental questions. How do we diagnose Parkinson's disease? Right now, we don't have a test. We don't have a diagnostic test that's a clinical diagnosis. We're wrong 15% of the time. And the second question is, how do we stop this disease? How do we slow down the progression? How do we prevent it? So I'm going to be talking about some really exciting news on biomarkers and new ways of perhaps making a diagnosis of Parkinson's disease and why that's important. And then I'm going to be talking about emerging therapies. And I'm going to be focusing on a couple of different kinds of topics. One is using medications for Parkinson's disease that already have been approved for other indications. We call this repurposing medications. And then I'm going to talk about a little bit about stem cell therapy and say a little bit more about exercise and nutrition from the standpoint of research. You already had some really excellent advice and presentations this morning on those topics. I'm just going to add a little bit to that in terms of what we know about research in those areas. So starting out with the biomarker issue, recently there has been a report of a new spinal fluid test to diagnose Parkinson's disease. And this is based on identifying through this alpha-synuclein seeding amplification assay the presence of abnormal synuclein in the spinal fluid of individuals with Parkinson's disease, okay? Now, you remember that to make a diagnosis of Parkinson's disease, pathologically, you have to have two things. You have to have one, degeneration of nerve cells in the substantia nigra that produce dopamine. And we all know that it's actually dopamine, loss of dopamine, that leads to the motor symptoms of Parkinson's disease. And then the second thing that you need is the abnormal deposition of this protein that we call alpha-synuclein in the form of Lewy bodies that are inside those degenerating nerve cells. So this test is actually able to detect abnormal alpha-synuclein that is clumped together and then deposited in these nerve cells in the form of Lewy bodies. So this test was recently studied in a very, very well-organized and well-done study from the Michael J. Fox Foundation called the Parkinson's Progression Markers Initiative, or PPMI. And this study includes people with Parkinson's disease. It includes unaffected volunteers, that is, people without Parkinson's disease. And then importantly, it includes people with early symptoms of Parkinson's disease, such as impaired smell and rapid eye movement sleep behavior disorder. And so when we think about these early symptoms, these symptoms actually start to occur years before the motor symptoms of Parkinson's disease, right? So as an example, impaired smell can occur at least 4 years prior to the onset of the motor symptoms of Parkinson's disease. Constipation has been an important topic. And yes, constipation is associated with Parkinson's disease, but actually it can begin to occur over 12 years prior to the diagnosis of Parkinson's disease. And then finally, rapid eye movement sleep behavior disorder is a disorder associated with REM sleep or dream sleep, where people have dream enactment behavior, where they act out their dreams. And this kind of condition can occur in individuals years before they develop the symptoms of Parkinson's disease, and seems to be linked to the deposition of this alpha-synuclein. So in this PPMI study, among people with Parkinson's disease, 87% had a positive test. And then very importantly, among unaffected volunteers without Parkinson's disease, 96 had a negative test. So this is what we call high sensitivity, the ability to identify people with the disease with a positive test, and high specificity. That is to say, if you have a negative test, you don't have the condition. So high sensitivity, high specificity. But for me, the most interesting thing about this study is that among the participants with the high risk of developing Parkinson's in the future, that is prodromal Parkinson's disease, the ones with impaired smell, rapid eye movement, sleep behavior disorder, 86% had a positive test, suggesting that maybe we could identify people who have a very high risk of developing Parkinson's disease just based on some of these very early non-motor features. So why is that important? It's important because when we develop therapies to slow down the progression of Parkinson's disease or to prevent Parkinson's disease, it's those individuals that we need to identify to start therapy as early as possible. So I think that is really the importance of this new diagnostic test. It is important from a diagnostic standpoint and confirming the diagnosis in people with the motor symptoms of Parkinson's disease. And I think it's going to be a very important way of helping to confirm the diagnosis in some patients when there's some uncertainty. But to be able to identify these individuals with very, very early symptoms prior to the motor symptoms, you know, one thing that we can do is recruit those individuals to participate in clinical trials with interventions that we hope will slow down the progression of the disease. So there are a lot of these biomarkers that are still in the experimental phase. And and some of them have to do with special immunological staining for this pathological or clumped alpha-synuclein that's present in other parts of the body and other parts of the nervous system other than the brain. And so, for example, we can actually identify this abnormal alpha-synuclein in the skin from some of these immunological tests. So at some point, there may be a skin test. Obviously, the blood is another place where we might be able to identify alpha-synuclein. And this alpha-synuclein seed amplification assay is actually under intense study right now, a blood test to identify this abnormal clumping of alpha-synuclein. And I'm hoping in the near future, instead of having to do a spinal tap to identify alpha-synuclein in the spinal fluid, we can just simply do a blood test. Finally, we've been talking, or some of our presenters this morning have been talking about how dopamine is produced, from amino acids like tyrosine. So one of the enzymes that's involved in the production of dopamine from tyrosine is dopa-decarboxylase. And high levels of this in the cerebrospinal fluid of people with PD can distinguish people with PD from unaffected persons. So this is another biomarker that we may see down the line that we may be able to use to identify with more certainty individuals with Parkinson's disease. So I'm going to move along now to emerging therapies, and I'm going to focus a little bit on some of these medications that are being repurposed for treatment of Parkinson's disease. And I'm really going to focus on treatments that are aimed at slowing down the progression of Parkinson's disease or preventing Parkinson's disease or halting it. Because that's where I really would like to see and as all of you would too, we'd like to find a cure. The medicines that we have and the interventions that we have now, they're very good at treating the symptoms, and we're very fortunate to have those. But for me, the important interventions on down the line are going to be the ones that can stop the disease process. So one group of medications are these glucagon-like peptide 1 receptor agonists. And there were some really great questions this morning about associations between diabetes and Parkinson's disease. And while there's not a direct correlation between presence of diabetes and Parkinson's in most studies, there is some evidence that the two diseases share some similarity in underlying pathophysiologic processes. And one of these is insulin sensitivity. So, there's impaired insulin sensitivity in people with diabetes, impaired insulin production, but there are also abnormalities in the brain of people with Parkinson's disease in insulin sensitivity. So, these medications that I know you've all heard about, I'm just going to say the word Ozempic one time because everybody has heard about that medication as a weight loss drug, but it is one of these GLP-1R agonists that's being used to treat diabetes. These medications increase insulin secretion and they promote survival of the pancreas cells, which of course is one of the problems in people with diabetes. Multiple studies also suggest that these medications are neuroprotective in animal models of Parkinson's disease. They restore dopamine levels in these models and they block dopamine cell loss. They reduce inflammation. And we've already heard some excellent discussion this morning about the role that inflammation plays in the cell loss associated with Parkinson's disease. It reduces oxidative stress, and it prevents clumping of that protein, alpha-synuclein, and promotes clearance of abnormal alpha-synuclein. So these medications seem to work on both of those pathological characteristics of Parkinson's, neurodegeneration or cell loss, of cells that produce dopamine, and abnormal clumping of alpha-synuclein and deposition in neurons in the brain in the form of Lewy bodies. So the other key about these medications is that there have been a couple of observational studies, that is large studies looking at big databases of people with diabetes. And individuals who have been treated with these medications seem to have a lower risk of developing Parkinson's disease in the future. So with that in mind, there have been several early stage trials. And remember, when we think about clinical trials, we think of different phases. Phase 1 is really the safety, looking at safety. And it may or may not involve the condition that you're really interested in. Phase 2 always involves the condition that you're interested in this case, Parkinson's disease. It's looking at safety, tolerability, somewhat efficacy and dose finding. And then phase 3 are those clinical trials where we really hope to show effectiveness of the medication. So in 2017, there was a phase 2 trial of one of these medications, exenatide, that reported the stabilization of Parkinson's disease motor features over the course of the 48-week trial. The group that was treated with exenatide demonstrated improvements, and what I want you to see on this graph here on the right is that the red line are those on placebo, and the measure here is the performance on the Unified Parkinson's Disease Rating Scale, and that's what we use to rate the severity of Parkinson's disease in clinical trials. And the blue line are those that were randomized to take exenatide, and you can see that their change is actually, not only did it not get worse, but it actually improved. And not only did it improve, but when they stopped the medication, that improvement persisted for a couple of months, suggesting that perhaps exenatide might actually slow down the progression of the disease. So where are we with this particular medication? Well, there are several more advanced phase trials. There's a phase 3 trial going on in the UK that I keep saying is going to be, results are going to be published soon, but I think that we'll start to see results toward the end of this year. There's another phase 2 study of a long-acting form of exenatide, and then there's a Swedish trial that is near completion that's another phase 2. So there are several of these medications, and several of them have been used to look at Parkinson's disease. And one that you've heard about recently from an article this month, in fact, in the New England Journal of Medicine, is lixisenatide. And this was the results of a phase 2 clinical trial that were published earlier this month in the New England Journal of Medicine. Participants in the treated group had no change in their motor scores on that Unified Parkinson's Disease Rating Scale, whereas those that were on placebo had worsening scores over the 12 months of the trial. Now, these aren't innocuous drugs, and I think it's important to note that half of those on the medication had significant nausea and vomiting. These medications slow transit sometimes in the gut, and people with Parkinson's, as we've heard already this morning, have difficulties with gut motility. And so a lot of individuals had difficulty with GI side effects on these medications. And a third of the individuals on the treatment, on the medication, could not stay on the highest dose. So there's work to be done, but this is really, really promising. Another one of these, liraglutide, a recent phase 2 trial results were published about a year and a half ago that's showing significant improvement in activities of daily living among people who were randomized to the medication. And again, they had nausea and vomiting and some injection site reactions. These medications are given by injection. So there is another fascinating medication here. I call it fascinating because it's so simple. It's called ambroxol, and it is an expectorant a cough medication, basically, that's available in Europe. I don't think that we can get it here. I've tried to find it, and I don't think it's available in the United States. But the interesting thing about this cough medication is that it is a potent enhancer of glucose cerebrosidase. Well, why is that important? Well, glucose cerebrosidase is one of the enzymes that's involved in the breakdown and clearance of clumped alpha-synuclein in people with Parkinson's disease. And we know that in everybody, and we know that people with Parkinson's disease have very low levels of this enzyme. Some of them actually have mutations in the gene that produces glucose cerebrosidase. And it makes them, they can't produce it like they ought to be able to, but some individuals just have low levels of glucose cerebrosidase. Well, this medication seems to be able to enhance production of glucose cerebrosidase. So one phase 2 trial with 17 participants found CSF levels, or cerebrospinal fluid levels, of glucose cerebrosidase increased, and movements improved in the individuals that were randomized to the medication. There are several ongoing trials, one phase 2 in Canada and a phase 3 trial that's ongoing in the UK, United Kingdom right now. Now this is one that I'm not all that familiar with actually. When I was preparing for this talk, I just ran across this one paper that I thought was really interesting. It's ursodeoxycholic acid, and it's used to treat gallstones. It's another one of these medications that is FDA approved for dissolving gallstones, and it was found to be neuroprotective in animal models of Parkinson's disease. And the interesting thing about this, we were talking about this a little while ago. One of the problems in people with Parkinson's disease is abnormal mitochondria. Mitochondria, as you remember, are the energy-producing components of the cell, right? The power plants of the cell. And in people with Parkinson's disease, there are particular parts of that energy production that are impaired, leading to loss of energy production in the cells and increase in oxidative stress. So this medication protects these mitochondria. And a recent phase 2 trial found that the medication was well tolerated and associated with improvement in walking among 30 participants treated for 6 months. As well as improvement in nerve cell function measured by an imaging test. So here's an objective called magnetic resonance spectroscopy. Here's an objective outcome showing definite improvement in individuals who are randomized to this drug. So I think we'll be hearing more about this in the near future. I'm going to say a little bit about cell replacement therapy, stem cell therapy. There are many different types of stem cells. The one that I personally feel like holds the most promise for Parkinson's disease are induced pluripotent stem cells. And these are cells that are taken from many different parts of the body. In this case, in case of Parkinson's disease, they're taking skin cells and they're programming those cells to become stem cells that can then be programmed to become any kind of cell, they can become cells that produce dopamine. And then the idea would be that those cells would be implanted into the brains of people with Parkinson's disease, and then they would be able to produce more dopamine and replenish the dopamine. Now, obviously, that would only affect those symptoms of Parkinson's disease that are caused by low levels of dopamine, right? But those are the motor symptoms. Those are the slowness of movement, the gait problems, and the postural stability problems. So there is a trial ongoing in Japan that has enrolled 7 individuals who have undergone these transplants. I was not able to find any recent updates, but as of a year ago, they had done 3 people, and so far there were no major complications. The interesting thing is, though, that there are a lot of trials being conducted. I won't say a lot, but there are several trials being conducted. There's one trial in Europe, in Sweden and the UK called STEM-PD that is just starting up. There are a couple of trials in North America that are just getting started using these induced pluripotent stem cells. So I think this is going to be something that we'll be seeing more of in the future. So we've already had an excellent presentation on exercise and Parkinson's disease, and they touched on the neuroprotective value of exercise in Parkinson's disease. So I just kind of want to bring this full circle and show you some of the clinical trials that have been done that have proven this. And there are two really recent ones, Park and Place and Sparks, that I really think bring this home. Park and Place participants were assigned to a stationary bike with gamer sizing. And this gamer sizing seems to be an important aspect of exercise. One thing, it makes it fun, but two, making it a game seems to enhance the protective effect of the exercise in individuals. And then Sparks is the other one. Participants were assigned to a treadmill exercise versus usual care for 6 months. Both of these trials found that high intensity exercise resulted in stabilization of motor symptoms in people with Parkinson's disease. Park and Place showed enhanced cognitive function, improvement in memory. And it also found improved preservation of brain function in the treatment group on functional MRI imaging, which I think is really important. These objective outcomes, the imaging outcomes that show improvement in these individuals. And then there are also positive benefits for constipation, sleep, and mood. So not just the motor symptoms of Parkinson's disease, but the non-motor symptoms of Parkinson's disease. Again, suggesting that exercise is having some kind of effect on the overall progression of the disease. So you already heard about high intensity interval training. It's designed to improve aerobic capacity, muscle strength and endurance, gait and balance, physical functioning and flexibility. There was a small trial that was just completed at Yale University that found that high intensity interval training is associated with reversal of the expected decrease in dopamine as measured by DAT scan imaging. Now, DAT scan is the individual is given an injection of a tracer that goes to the dopamine transporter in the brain, and the dopamine transporter is a direct reflection of the number of dopaminergic cells. So what you see in Parkinson's disease is loss of these dopamine transporters, and you can measure it, and it's usually asymmetric, and it helps us to confirm a diagnosis of Parkinson's disease. So in this trial with high intensity interval training, those that got this training had improvement on their DAT imaging. So I think that that's really exciting. We've also heard some really good discussion on diet, and I am certainly not here to push any certain kind of diet, and I thought that was brought out really well earlier this morning. There is no single diet that is better than another, but there are tips that we can take from a lot of these, and one of them is the Mediterranean diet. It's rich in fruits and vegetables and beans and cereals and low on red meats. We've already heard about that. It's associated with a reduction in blood fats and, importantly, reduction in inflammation and oxidative stress. And I think Dr. Gab brought that up a little earlier. Improvement in insulin sensitivity, enhancement in blood vessel lining, and a more favorable gut bacteria. So several studies have reported decreased risk of Parkinson's with greater adherence to the Mediterranean diet, as well as slower progression in older age. Now, these aren't definitive studies, but they're studies that, in my thinking, make it a no-brainer to try to adhere to a diet like this. What do we have to lose? These are great diets for a lot of other things besides Parkinson's disease. So to me, this is exciting and something that we can do right now. 2 studies have shown decreased risk of developing prodromal, and that's that Parkinson's disease that has some of the non-motor symptoms of Parkinson's without the motor features. So I'm going to close now. But I want to say one of my mentors in research was Jerry Boster. And you all know Jerry. He was president of this association that has put on this spectacular symposium for many years. But I think Jerry would be fine with me saying that we met through a clinical trial. And he became the biggest advocate for research in our community that has existed. And he was tireless. He was always anxious to participate himself. He always encouraged other people to participate in research and in clinical trials. He did it on a local basis, and he did it on a national and international basis. And so I just want to highlight some of the really excellent work that's being done in our community, work that you can participate in, hopefully. One of these is the TOPAZ trial. This is a trial, and this is being done at Queens, and you already have a display over at the table over here, so come speak to Emma afterwards. It's a trial of Parkinson's disease and zoledronic acid to prevent bone fractures in people with Parkinson's, and obviously, people with Parkinson's have frequent falls, so they have frequent fractures. So this is hopefully a medication that might reduce the number of fractures. And then there is a Michael J. Fox Foundation study that's ongoing at the Queens Center with Dr. Bruno to examine racial and ethnic disparities in healthcare among Native Hawaiians and other Pacific Islanders. There have been 2 important papers that have been published recently, and I have to say that I am honored and very happy to be one of the investigators associated with this project. One paper showed that Native Hawaiian and other Pacific Islanders and Filipinos with Parkinson's are hospitalized at a younger age and have more illness than white and other Asian subgroups, suggesting there are disparities among these groups. And then the second one showed that Native Hawaiian and Pacific Islanders and Filipino people with Parkinson's are hospitalized less frequent than other groups. Now, we don't know the reasons for all of this. And so importantly, Dr. Bruno has a study ongoing now that's kind of a pilot study to try to enroll individuals with Parkinson's disease and follow them over time to try to get more answers about why we see these disparities in healthcare. And they're very close to completing their goals of recruitment, but I think they still have a few more slots left. So if you have any questions, come over to the Queen's table over here, because I think that they're doing really important work. Hawaii Pacific Neuroscience also has clinical trials ongoing right now. There are at least 2 and perhaps 3 trials. There's a double-blind study to investigate the efficacy and safety of buntanetap compared with placebo in people with Parkinson's. This medication inhibits the production of toxic proteins, including alpha-synuclein. And it's hoped that this may reduce inflammation, preserve neuron processes and nerve cell connections, and hopefully slow down the progression of Parkinson's disease. And then the other study that is recruiting at Hawaii Pacific Neuroscience is this it's an early phase study of this experimental medication BIIB122 to see if it can slow worsening of early stage Parkinson's disease between the ages of 30 and 80. So here's a picture of Jerry. I just want to say that in addition to these studies, there are also a couple of proposals that are very promising. One is hula MPD, and I'm really hoping that that will become funded. And then the second one is harmonica, and that one as well. These are other kinds of exercise that may benefit or slow down the progression of Parkinson's disease. So I just, in closing, I want to just say a couple of things about earlier questions. One was creatine, and Kevin had mentioned a creatine study. This was a Parkinson's study group trial that went on about 5 or 8 years ago. We were fortunate to be a site in that trial, and creatine has a lot of positive characteristics for enhancing exercise stability over time, and there are some indications that it has antioxidant properties and other properties that might be beneficial in people with Parkinson's. Unfortunately, it was a negative trial. So I cannot recommend creatine, and to my knowledge, I didn't see anything about fluid characteristics or liquids in those individuals who were on creatine compared to those that were on placebo. And then just a word about medical marijuana. If you want to know more about marijuana and Parkinson's disease, go to the Michael J. Fox Foundation website. They have done a lot of work on this topic. And there is, as already was mentioned this morning, there's very little good information from clinical trials on marijuana and Parkinson's disease. You can go online and you can see all kinds of great things with smoking a reefer and treating Parkinson's disease. But personally, I wouldn't take that as evidence. Unfortunately, the bad news is that we don't have a lot of clinical trial information. What we have is kind of mixed. There's nothing really exciting going on as far as I can tell. But the good news is that there are actually trials going on right now that are looking at the treatment of some of the symptoms of Parkinson's disease with marijuana or THC. So with that, I'll close, and I think I've overstood my time, but thank you very much for your attention. Thank you.
All right, you made it. Good job. Okay. Well, I'm going to turn it over to Glenn, the president of the Parkinson's Association, for closing comments. And thank you guys for your attention today.
Yeah, I know everybody was ready to go and leave, but first of all, another big hand for Dr. Ross. We actually should just close this on Dr. Ross saying reefer. We should just leave on that note. Also to our panelists as well, thank you very much. And to our moderator, Kevin Lockett, for keeping us on time. Thank you, Kevin. Good job. Okay, so a couple of announcements. Actually, first things first. All those with Parkinson's, if you can stand up, please. If you are able to stand up, everyone who has Parkinson's, please stand up. If you're able to. Okay. Now I want you to give a standing ovation to all the care partners in the room, because they are the true heroes of all of us. Okay, you guys can sit down. Thank you. Okay. Couple of notes that I want to finish up with. If for those of you who parked in the valet parking, it does close at 12:30. So if you're planning to stay past 12:30, go get your car, move it to the parking lot. Okay. Couple other things. One more thing. Please fill out the survey that's in the program book. Okay, and leave it on the table on your way out. We greatly appreciate it. It will actually help us make this symposium even better next year. Okay. The HPA walk is coming up on November 9th. Okay, that will be a Saturday, Magic Island. Okay, bring your ohana, make a day out of it. Okay, that's the theme this year is ohana. Okay, and finally, if you only take away one thing from today, from this symposium, it's worth it. Okay, it's worth it. Okay, so if you only took away one thing, it's worth it. Okay, but remember, okay, exercise, especially high intensity and high-intensity training has been proven to slow down or delay the progression of Parkinson's. Okay? Hydrate, hydrate, hydrate. Okay? And remember, speak with intent and swallow with intent. Okay? So that's my takeaways from today. Thank you very much, everybody, for coming out to our symposium. Hope you all had a great time and you enjoyed yourself. Take care and drive home safely, and aloha.